number 52 of the House of Commons Standing Committee on Health. Today we meet for 2 hours with witnesses on our study of children's health. Today's meeting is taking place in a hybrid format pursuant to the House Order of June 23rd, 2022. A few comments for the benefit of witnesses. Interpretation is available for those on Zoom. You have the choice at the bottom of your screen of either floor, English, or French. Screenshots or the taking of photos of your screen is not permitted. The proceedings will be made available via the House of Commons website. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting. And just before introducing our witnesses today, colleagues, you will have had circulated to you just today, I believe, a pretty extensive interim summary of evidence for this children's health study, as was requested at an earlier meeting. It's outstanding and timely work done by our analysts that I'm sure you're going to find quite helpful. So with that, I now welcome our witnesses who are with us this afternoon. Madam Catherine Heck, professeur titulaire, département...
A full professor, Department of Economics, Université du Québec à Montréal, by video conference.
Bukola Salami, professor in the Faculty of Nursing at the University of Alberta. Ms. Leila Sarangi, National Director, Campaign 2000, who's joining us by video conference. And Susan Bizayon, Chief Executive Officer, Safe Haven Project for Community Living. Thank you for taking the time to be with us today. Each of our witnesses has up to 5 minutes for an opening statement. Et on va commencer avec...
And we'll begin with Ms. Heck. Thank you for appearing. You have the floor. You are on mute. I see. I had been put on mute. All right, fine, thank you. So I'm pleased to be with you here today. I'm a full professor at the Department of Economics at the Université du Québec à Montréal. I'm specialized in the economy of education and labor. My research in the past 15 years concentrated exclusively on children and families and inequality, the transmission of inequality across generations. So in all my research, I pay special attention to large-scale interventions and programs that aim at children and families. I use high-quality microdata with causal inference techniques in order to assess the welfare of families and children. So I've done many studies on many topics, prenatal nutrition programs in Quebec, reduced daycare costs in Quebec, children who have to repeat a grade. Many topics were covered. When the pandemic started, I was contacted to conduct studies on the development of children in the pandemic context, and I read everything that was written about the impact of closures of schools on children and youth. In that context, what I noticed and read is that there was a great deal of information on what was going to happen. We weren't completely in the dark. There had been events in the past from which lessons could be learned, and we saw that when schools are closed, learning gaps tend to grow. What happens often is those who find school easy continue to perform well and find it easy. Those who have more difficulties fall back, and the longer school is closed, the more that gap widens. So we felt there'd be an impact of about 30% in the increase in the gap between the best students and the weakest following the closures in the early part of the pandemic in 2020. That was published in Canadian Public Policy, a serious publication in Canada, published in the summer of 2020 during the pandemic. After that, there was more and more research everywhere that confirmed an increase in the gap in performance. I became co-director of the Observatory on Children's Health at St. Justine Hospital here in Montreal. That observatory was created to follow the development of children during the pandemic and evaluate various strategies and interventions that could mitigate the effect of the pandemic on children, especially lockdown measures on children. So there are many researchers in this observatory that do a lot of work on the impact of the pandemic on children. One of the studies we conducted was with the Ministry of Education of Quebec, when we had a standardized test for 10,000 children in Quebec to find their knowledge of French, particularly reading. The test we used in June 2021 was the same one that had been used by the government of Quebec in June 2019. So we could really compare apples with apples here. The children did the test in June 2021, and what we noted that the top 20% who find school easy always succeeded just as well, whereas the weakest children had really fallen behind, and these results were confirmed with the recent results we saw in Quebec with the ministry exams that took place in June 2022. So that's no surprise. We expected it. We knew it. I appeared in a lot of media in April 2020 to try to alert people that closing down schools was something you had to be careful about, be sure that that was a good practice. There were other studies conducted in mental health by people at the observatory, but other things were observed worldwide. We really see the impact on mental health. We see it at St. Justine. There's an increase in suicide attempts or suicidal ideation. Yesterday, we updated that data in Quebec, and we see that that trend is continuing to increase. We have more hospital visits for these reasons. So we're seeing a deterioration of our youth's mental health. We're seeing the same thing in terms of physical activity, the amount of time spent in front of a screen, and so on. I think my 5 minutes are up. I could continue to talk about these topics for a long time, but these are not negligible effects on children because of the measures that were chosen in Canada. Thank you very much, Ms. Heck.
I hear from Dr. Salami, professor in the Faculty of Nursing at the University of Alberta. Welcome to the committee, Dr. Salami. You have the floor for the next 5 minutes.
Thank you so much, Mr. Chair, for the opportunity to speak to you today on children's health and COVID-19 recovery. And just to be reminded that we are situated on the unceded territory of Anishinaabe, Algonquin Nation, and I pay respect to First Nation, Inuit and Métis people of Canada whose presence continue to enrich our vibrant community. I'm a professor at the Faculty of Nursing, University of Alberta, and I'm also the Director of Intersections of Gender Signature Area, which is one of 5 main signature areas of research excellence at the University of Alberta in the Vice President Research Office. My area of research is racialized Black people and immigrant health in Canada, and I've been involved in around 8,500 research studies on this topic. We know, according to the UNICEF report on child health globally, and it's been discussed over in previous sessions, we know that Canada has poor health outcomes for children than other high-income countries, ranking 30 out of 38 countries in 2021. Canada has one of the highest rates of adolescent suicide due to health inequities. And I know Mr. Don Davis and some others have asked the reason why we rank so poorly. If we want to make a significant cut to that, it would be for us to consider the inequities that Indigenous children face in Canada. For instance, Inuit people have 6.5% of suicide rate than non-Indigenous people in Canada. So if you have that, you'll be able to make tangible and sustainable gains. Addressing health disparities faced by Indigenous population will yield many gains and improve child health outcomes in Canada. We have seen the consequences of these inequities in the case of COVID-19 pandemic. Prior to the COVID-19 pandemic, authors have largely said that income was the strongest social determinant of health. Well, COVID-19 sort of told us that that may not be the most accurate. COVID indicated that racism can reproduce as well as intersect with income to contribute to poor health outcomes of poor population health outcomes. Data from Montreal, Toronto, Ottawa, and other cities indicate that neighborhoods with the highest number of Black population have a higher rate of COVID-19 than neighborhoods with lower concentration of Black people. In 2020, being Black was associated with increased risk of death from COVID-19. And the influence of the concentration of Black people in the neighborhood was much stronger than the influence of income inequality in the neighborhood. The central reason of these disparities is not biological and it's not genetic. It's rather because of systemic and structural inequities and racism and the inequities that this racism reproduces, including income inequalities and spatial inequalities. Over the last 1 year, we have interviewed Black youth in Canada, and we've also surveyed or are in the process of surveying around 2,000 Black youths in Canada to shed light on the impact of COVID-19 pandemic on their mental health. What we know from the interview, from 2020 to now, Black youths have been dealing with two pandemics. One is the COVID-19 pandemic, and one is the pandemic of the Black Lives Matter movement. Black youths have experienced both over surveillance and also re-traumatization from constantly watching news about Black Lives Matter movement. For many Black youths, also, sport is their outlet to de-stress and to overcome many of societal inequities. The closure of recreational facilities and lack of access to sport had an impact on the mental health of Black youths. Financial and food insecurity was a challenge for youths. Youths, especially those with disabilities, informed us of their experience of begging for food, going to churches just for the purpose that they know there'll be food available in churches. Some youths experienced separation from their families and challenges reuniting with their families due to border closure and immigration restrictions. Youths also experienced barriers in accessing mental health services. While virtual delivery of mental health services provided some solution, it also caused some challenges. Youth indicated that virtual delivery of services contributed to lack of empathy by service provider and that it was often a challenge to maintain confidentiality. So sometimes a service provider will call you and your parents are right there. You don't really want to verbalize. The lack of representation of Black people in health service provision is a barrier to accessing mental health services. Despite this, Black youths are resilient. Youth drew on their inner strengths, community, and spirituality to improve their mental health. Based on this finding we have conducted so far, there are some recommendations. One is to reinvest in sports participation for youths, to invest in targeted intervention for high-risk racialized population, especially Indigenous and Black youth in Canada, to invest in programs that strengthen community belonging and positive identity, such as parenting programs and mentorship programs, to address racism experienced in the school system, to diversify the health workforce, improving access to the profession for internationally educated professionals, implementing measures to ensure the upward mobility of Indigenous, Black, and racialized professionals, and mentorship of Black, Indigenous, and racialized youths. And also to include accountability in anti-racism initiatives, including having anti-racism as an evaluation criteria and the standards of practice for all healthcare professionals. To build and capitalize on the resilience of Black and racialized youths, amplifying public information about the contributions of Indigenous people and Black people to Canada, and to build the capacity of informal support networks, such as churches and community leaders, who are often the first point of contact in cases of mental health challenges. And I believe these challenges, these strategies will contribute to positive health outcomes among Black, racialized, and Indigenous populations in Canada. Thank you.
Thank you very much, Dr. Salami. And next, Leila Sarangi, National Director, Campaign 2000. Welcome to the committee. You have the floor.
Hello, and thank you to the chair and members of the Health Committee for the opportunity to speak today. Campaign 2000 is a nonpartisan pan-Canadian coalition of over 120 organizations working to end child and family poverty. We submitted a brief to you that we co-authored with colleagues at Proof, a research program based out of the University of Toronto that focuses on policy interventions to address food insecurity. We are recommending several changes to the Canada Child Benefit as a key tool for the federal government to improve children's health. These recommendations would enable the CCB to have a bigger and a broader impact on reducing poverty and food insecurity in Canada. Our recommendations are to, 1, increase the CCB amounts for the lowest income households so that there is a targeted focus on families living in deep poverty by creating an end child poverty supplement for families living with incomes below the low income measure as modeled by the 2023 alternative federal budget. 2, to create an additional supplement to provide more money to low income families in remote and northern communities. 3, to enable families with precarious immigration status to be able to access the CCB. Many are considered residents under the Income Tax Act, but eligibility of the CCB is arbitrarily tied to immigration status, which means that even though these families work and file taxes and may have Canadian-born children, they are ineligible for the benefit. And 4, to end the ongoing clawbacks of the CCB for moderate income families who received emergency pandemic benefits. There is an inextricable link between poverty and ill health. Research shows that poverty is causally related to children's developmental outcomes. Poverty is one of the strongest and well-established predictors of poor health and child development. In 2019, more than 1.3 million children, or nearly 1 in 5 children, lived in families with low incomes in Canada. Their average income was 37% below the low income measure. This is a matter of health equity, as we just heard, since child poverty rates are significantly higher for groups who facing colonization, systemic racism, and marginalization. In 2020, despite a global pandemic, we saw rates of child poverty reduce significantly because of large investments into income transfers for families. These benefits have all expired, and Statistics Canada is predicting that poverty will return to pre-pandemic levels. Household food insecurity is the inadequate or insecure access to food due to financial constraints. It is a potent social determinant of health with associated health disadvantages being similar to those with low income. Living in a household struggling to afford food is toxic to children's health and well-being in ways that are not limited to poor nutrition. These children are at greater risk of mental health problems like anxiety, depression, and suicide ideation. Food insecurity is not just about food, but rather the household's financial well-being. It is a marker of pervasive material deprivation, and at its core is a problem of income inadequacy. The persistently high proportion of children living in poverty and food insecure households demonstrates that the CCB has not provided enough money to enable families to be secure. In 2021, 1.4 million children lived in households affected by food insecurity across the provinces. In Canada, the mere presence of children in a household increases the probability of food insecurity. The situation is especially dire in Nunavut, where almost 80% of children lived in food insecure households. As the primary federal policy supporting low-income families with children, the CCB has the potential to have a much larger impact. It is currently failing to live up to this potential because it is not providing enough money to lift families out of poverty, and there are barriers to accessing it for families from systemically marginalized communities. The exceedingly high proportion of children affected in Nunavut also demands special attention in the form of an additional supplement for northern families that address the high cost of living. Policies that have increased the financial resources for low-income families have repeatedly shown to lower food insecurity among families. Considering the strong relationship between food insecurity, poverty, and health, the Canada Child Benefit is very much a health policy. CCB enhancements and reform stand to protect children and their families from circumstances that are very toxic to their health. Thank you for your time today, and I look forward to answering any questions.
Thank you, Ms. Sarangi. And finally, Susan Bissayon, Chief Executive Officer, Safe Haven Project for Community Living.
Thank you.
Welcome. You have the floor.
Thank you for inviting me here today. Safe Haven is an organization that provides community-based care, respite and residential to children, youth, and adults who live with complexity and medical needs and disability. We've been around for over 35 years. We have 6 locations in the Greater Toronto Area. We believe that our clients have the right to belong in all aspects of society, and we're continually striving to advance our work towards inclusiveness with our We Belong movement. Today, I'd like to highlight how investments into community-based care models for children and disabilities can liberate capacity in our struggling hospitals, provide choice, and enhance the system of care. As well, I'd like to identify the need for providing enhanced funding to support individuals directly, along with the need for creative housing solutions to ensure that individuals with disability are able to transition into adulthood with dignity and respect when they turn 18. While our organization operates in Ontario, I know I speak for my colleagues across the country as our funding and system of support for vulnerable individuals in Canada is inadequate. Safe Haven is a unique provider in the province and across the country because we care for children with incredibly complex needs and rare conditions. We are a critical part of the care continuum with our children's hospitals who are continually under siege with capacity limitations and challenges with health human resources. Many of our clients come from sick kids and Holland Bloorview after very lengthy hospital stays. Our current system is failing our kids, but we have the opportunity to make it right. Safe Haven cares for the most vulnerable children, the ones who were never expected to make it. But thanks to medical advancements, innovations in care, and some of the best pediatric hospitals in the world, these children's lives are being saved, and many are now living into adulthood. The physical, emotional, and financial burden on families to care for a child with complex special needs is enormous. If they are able to care for their child at home, almost always one of the parents are required to quit their job and stay at home as a full-time care provider. But some families cannot cope and resort to giving their children over to government care, an act of desperation because they have no other option to access help, support, and services because of the long wait lists. I'm sure many of you here today are parents and see this as being unconscionable, yet this is happening in our country. Ontario's Financial Accountability Office detailed wait lists for children's services grew in 2012 from 1,600 to 27,600 in 2020. Safe Haven regularly hears firsthand from families in need of services for their children with developmental disabilities. We are met with requests weekly from families across the province. For respite care, we were able to accommodate half of the families that request care due to capacity and eligibility restrictions. There's a particular challenge with transition from children's services to adult services because these children were never supposed to make it to 18. An integrated system of care was never developed for the duration of their lives. Parents describe going from childhood into adulthood like falling off a cliff. Instead of celebrating their 18th birthday, this is a dreaded milestone. As well, individual funding supports is extremely low for these children who age into young adulthood if they survive, and they're forced to live below the poverty limits. As Bill C-22, the Canadian Disability Benefits Act, progresses towards the Senate, I want to emphasize the importance of supporting programs like Safe Haven that promote the inclusion of inclusionary care for the most vulnerable. Specifically, children and those who transition into adulthood need a stable income and an affordable housing. These individuals deserve the right to life as well as anybody else or any other healthy child, as young adults should not be sent or even considered for long-term care. Our proposed solutions focus on investments that need to be made now to make available spaces and programs for children, youth, and adults that addresses gaps in our current system, enhanced support for families who want to keep their children at home, and good respite programs and residential programs for those parents as they age and no longer can care for their children. Also, medically complex individuals need financial support to ensure they escape poverty. The very complex children I'm speaking about today need a lifetime of care from infancy to adulthood. These are considered medical miracles. We need to ensure that they are living longer and that we have a system in place that can care for them. They will never outgrow their disease, they will never recover or get better, but they have a right to a safe and secure home and a system of care for them while they are alive. If we do not address the needs, the gap will only continue to widen. These vulnerable children and their families deserve better. The mantra of safe haven, we belong, aligns with the 4 pillars of the C-22 new legislation being proposed: financial security, employment, accessibility, and inclusive communities, and a modern approach to disability. We should all aspire to achieve a world where our kids belong and a part of inclusive environments and communities. Thank you.
Thank you very much, Ms. Bizion. We will now begin rounds of questions, starting with the Conservatives. Dr. Ellis for 6 minutes.
Well, thank you, Chair, and thank you very much to the witnesses. Certainly, it's interesting at this particular panel to see all of your statements from a very different perspective, and hopefully we'll be able to have a rich discussion. I think, I'm a former family physician, and certainly I think one of the things that makes me the most sad is really understanding the plight of children in this country and how government is failing them in terms of the financial needs that they have at the current time, and we know that that's been declining. Dr. Salami, I have a question for you, specifically related to the pandemic. You talked about perhaps particular difficulties that children from racialized communities may have experienced during the pandemic. At some point, I would suspect that this committee, or at least or perhaps Parliament as a whole, will need to address the pandemic response. What I would like from you, if I could, what do you think we should have done differently during the pandemic?
Well, I think, not as much during the pandemic, but I think it's what we should also have done before the pandemic that we should have done. And I think, one of the things that we didn't do so well is addressing issues related to systemic racism that contributes to childhood inequities. One of the big things that we didn't do well was race-based data collection before the pandemic. Before the pandemic, we didn't really know in terms of, the disparities in health outcomes, for example, related to children. We know, I did a review of the literature, and I found a lot of studies that had been done on immigrant child health, but we oftentimes did not disaggregate that data by race. So we lump everyone together, and then we're expecting to be able to find a solution where we know that if we had disaggregated the data and we looked at indigenous people separately, Black people separately, we would have been able to have much more targeted response to this. The other thing that we didn't do too well, that we started doing much better during the pandemic, is capitalizing and mobilizing opportunities related to healthcare professionals and health service providers, Black and racialized health service providers. And that's one thing that has changed during the pandemic, is we now have much more Black organizations that have, emerged, probably also as the influence of Black Lives Matter movement. So we have, for example, Black Physicians of Canada, Black Physicians of Alberta, and also Black Nurses Group. I think what we need to continue to do now is how do we capitalize on some of the strengths of some of those organizations to be able to move some of our approaches and interventions along and positively influence the needs of communities.
Thank you for that, Dr. Salami. I appreciate it. For Ms. Bizion, please. You talked a lot about children with rare diseases, and certainly we see that in children with disabilities and rare diseases. That's transition into adulthood, often the transition from children's hospitals to adult hospitals. We often have that difficulty. Canada, I think, is the only G7 country without a rare disease strategy. And I'm wondering if you have any comments on that, on the difficulty it presents for children with rare diseases and perhaps disabilities in general.
Well, thank you so much, and you're absolutely right. we do not have a strategy. And I know rare disease, but many of these kids that we have, like their conditions have been diagnosed. So I speak for individuals with medical complexity and rare disease. Many of these kids they were never expected to become an adult. And I think that's what I'm grappling with every day is, like I said, these kids were given a home for life in Safe Haven when we started 35 years ago. But you can see medical technology. We have kids on ventilators. We have kids who are on G-tubes. So we're able to really sustain life with a lot of medical technology. So these kids are really set up to actually live into adulthood. But the issue is they require a life of care. And the transition from children to adulthood is incredibly difficult. There is no well-established system. So when you talk about rare disease medical complexity, we need to have a very thought-out transition program and a safety net. And that's one thing that I'm proud of. We just introduced a new program for 14 adults that successfully transitioned from childhood into adulthood. That actually was supported, by the Ontario government. It is a bit of I would say, not very usual across the country. But I do think that it's really important that we think of it when these children are born, that they can potentially go into adulthood. What does that look like? And then how can we support them? We also need to make sure that they have a home. You cannot think of good health in the absence of a home for these children. So I hope I've answered your question, but I think for sure we definitely need a very comprehensive, well-developed strategy from childhood to adulthood to support children with medical complexity and rare disease. And I'd love to be a part of that and see it happen.
Thank you very much. And I know we have limited time, Chair, but I'm wondering, Ms. Bizillon, if you could table with the committee your actual approach to that transition for children from childhood perhaps into adulthood. I think it would be interesting for us to see.
Yeah, so just to give you a sense, I joined Safe Haven just over 5 years ago, spent most of my career in large academic health science center. Certainly have been very well exposed to the notion of medical complexity. We developed a program where we felt it was important that it was seamless. So when I first said we were going to create a seamless program from children to adulthood, I think people really kind of looked at me and said, okay, that's very ambitious. We just actually successfully transitioned those 14 individuals in the first of this month. So we created spaces. We actually partnered with an organization so that we could have housing for them. So they have secure housing. They have 24/7 care provided. They are now in what's considered an adult location. So they have a home. And it's really exciting for us. I think we're doing something that was never thought possible. I do think that this is a model that can be actually packaged, scoped, and spread across the country. I'm in touch with my colleagues in British Columbia, in the East Coast. I know that it is possible. What it requires is a commitment and partnership with government at all levels to really look at housing, look at how we actually transition the funding models that go with it. So they need to have funding for the housing, and they also need to have funding for the care. So it's really good looking at that comprehensive approach to a system for housing and care. Like I said, we've just done the first 14. These are very complex kids. These are kids that lived in the hospital for a decade.
Thank you.
Thank you.
We want to try and allocate the time fairly so everyone gets a chance.
Sure.
Next, Dr. Hanley, please, for 6 minutes.
Thank you very much to all of the witnesses for coming. Really interesting topics, and I think if there's one common theme emerging, it's about increasing what we see in disparity in health outcomes when there's a stressor, whether that stressor is the pandemic, whether it's economic difficulties, racism, disparities are accentuated. And I just want to go first for Madame Heck. I hope j'espère que je prononce votre nom.
I hope I'm pronouncing your name properly. With some dignity.
If there are some ways that we can help to build resiliency to enable children at higher risk for worse outcomes to do better under stressful circumstances, whether that's pandemic or the next stressor. How can we do that? And if I could ask you to be fairly brief as well, because I have some other questions.
Yes, my pleasure. Pardon, en français.
I'm sorry, I'll answer in French. Yes, I'm pleased to respond to that. Essentially, if you think of children, you have to think of all dimensions of children's lives. The biggest ecosystem in which most children live is either daycare or when they're older, school and at home when they're smaller. So preserving everything where they develop is essential. We've seen this in the data. It's striking. When you close down schools, the most vulnerable children are the most affected because there's a whole ecosystem around the school that helps those children. Through the schools, for instance, those children are helped even more than what they are now. That would be desirable, but preserving those systems, keeping those services open, preventing these shocks is very important for their families. I could speak to this a long time because closing schools had an impact on parents too. When you think of children, if you affect parents, you affect children too. So we have to be very careful when you're talking about children and have policies and programs. We have to preserve things for the most vulnerable because the most successful will always manage. They have all kinds of mechanisms around them that will continue. But the most vulnerable, as soon as things change, it can become dramatic. Long-term school closures were catastrophic. There was no remedy to that, if I'm honest with you. There is no way to compensate for that daily human contact. Trying to do that with Zoom, especially when you're talking about young children, it doesn't work at all. It's completely pointless. Thank you very much. I hesitate to cut you off, but it's a very important question. That was very important to hear. For us.
I wanted to thank you for highlighting income disparities as a determinant of child health and for highlighting that gap. And you talk about additional support for northern families, particularly Nunavut. But I wanted just to focus on what you suggest about CCB. And if we were to look at how we were to improve CCB, especially targeting perhaps, again, children more at risk, could you elaborate a little bit on how you would see that working, how you might suggest that be structured?
Through the chair, thank you very much for that question. The 2023 alternative federal budget that gets released annually through the Canadian Centre for Policy Alternatives has put forward a model that is income tested. So it's a supplement to the Canada Child Benefit that is income tested using tax filer data, the poverty measure that is calculated with tax filer data, that is the Census Family Low Income Measure after tax adjusted for family size. It's a relative measure of poverty that is based on median income. And so anybody who's falling below that 50% median income is considered to be poor according to that measure. And so this supplement would be targeted to those families below the low income measure. It would give them additional income based on the number of children they have.
Point of order, Mr. Chairman. Mr. Garon, I understand there's construction next door. I don't know if there's a torture chamber back there, but the fact remains that the interpreters are having trouble interpreting as a result because of the noise.
Merci, Monsieur.
Thank you, Mr. Garon. I'm informed that we tried to contact the workers and have them stop. If you wish, we can suspend the meeting until it works again.
Okay. Are we doing that now? Quelqu'un est là pour
Somebody is there trying to solve the situation.
OK, je pense que
I think it's being solved. It's improved anyway. Dr. Hanley.
about another 90 seconds.
Okay, and thank you, Ms. Sarangi. Maybe I'll take this opportunity to move to another question. I think you pointed out a useful reference there. I wanted to move quickly to Dr. Salami and then save a few seconds at the end. But Dr. Salami, we heard a story on the media today about the lack of research on Black Canadians and cancer outcomes, and it led to that theme of the research environment is enabling adequate research on racialized or marginalized Canadians. I wonder if you could comment generally on how you see the adequacy of funding and whether there are ways that we should be improving that.
Yes, as I said earlier, we have really a lack of data, disaggregated race-based data, and there's a strong need for disaggregated race-based data. So when you talk about cancer, I just did an analysis of the Canadian Community Health Survey where I found, Black people, 18% of Black population have never had the pap smear in their lifetime. For white Canadians, it was 7%. That has consequences for health outcomes. And as you said, there's disparities in terms of data in cancer outcomes. I think we need to do more, even in terms of children, to be able to address, some of the disparities children face. We need the data out there. We need investment in research to be able to both uncover what those disparities are and what are the best approaches to addressing some of those disparities.
Thank you. Do I have any remaining?
You
time?
do not.
Okay.
Thank you. Sorry for the interruption, Dr. Hanley. Mr. Garand pour 6 minutes, s'il vous plaît.
Merci, Monsieur le Président.
Thank you, Mr. Chairman. I want to confirm that there's no torture in Canada. I wanted to withdraw what I said earlier, and I'd like to thank all the witnesses for having been here today. My questions would be for Ms. Heck. Last fall, there was a witness from the government, an official, who came before the committee. And following one of my questions, she said that there were no studies about the school closures and lockdown on the health of children and mental health. So I'm a little confused here because in your opening statement, you pointed out that such studies did exist. Could you confirm that that's the case? Yes, these studies do exist. They've existed since before last fall. Many things have been done during the pandemic. As I said earlier, in the summer of 2020, we were already publishing things that gave us an idea based on what we knew then from prior literature on what would happen following school closures. Now we have real studies that were published this past fall. Okay, thank you. We're talking about child health, but it's important to talk about health funding. We know there's a major meeting between the premiers and the federal government happening today. I get the impression that our health systems were underfunded and have been for a long time. We had a lack of federal transfers for a long time, and to a certain extent, children paid for adults. In order to protect adults who had severe COVID, schools were closed because there was use of hospitals. So I'm wondering if that chronic underfunding of our healthcare system indirectly impacted child health. That's important. It is federal. Health itself is not federal, but financing is. So do you agree with my interpretation? I completely agree. My colleagues in Belgium had school closures for less time. I did my PhD in Belgium. They have more healthcare capacity. They could absorb the cost. They reopened the schools before the end of the year, the first years when we closed them down. In 2020, they reopened schools. They measured the impact of the 7-week closures. They had excellent data, super data. We don't have that. So the capacity of our system hurt our children, and they paid the price. They continue to pay the price. This is far from over. I'd like to point that out. Adults may have gone on to something else, but children are still suffering. Thank you. Here in Ottawa, we have people who want conditions for healthcare transfers, but there are needs everywhere. So all the groups are appearing here and asking for conditions in their own domain. So I think that we lack funding across the board. We need conditions everywhere when we need conditions nowhere. It's particularly true for mental health, which is not an area of federal jurisdiction, but we do have a minister of mental health here in Ottawa. So I'm wondering, if we had better funding of healthcare that's stable, predictable, non-conditional, in the past few years, could we have done more prevention in terms of mental health among children? And if so, what effect would that have had today or during the pandemic if more prevention had been done beforehand? Well, let me give you an example. I did a study of 8,000 children in Quebec. What we see is we cannot diagnose attention deficit, ADHD in Quebec, not just in Quebec, everywhere in Canada. That has to happen. So what we're seeing is because we're not investing enough in child health, we can't have correct diagnoses. So we end up medicating children for nothing, and we don't know the long-term effects of that medication. That's just one example among many. That's not prevention. Since we're underinvesting, we're doing things too quickly, too hastily. It has repercussions on schooling. Educators are stuck with kids that are not properly treated by the healthcare system. So I'm calling upon your knowledge of this whole area. Do you get the impression that the federal government here in Ottawa is well positioned to design services and plan mental health services, tell the provinces how to orchestrate them? Do you think that the brains of this whole thing should be in Ottawa to deliver services to children if we want to have prevention services for mental health? No, because it requires on-the-ground expertise. You have to figure out how to deliver the services. You have to do that close to the ground. Ottawa does its best, but it's far from being on the ground. It is not in a position to make those choices. We have to leave that up to the provinces. Each province has different realities, too, in their cultural communities, their healthcare problems, and vary from one region to another. So you have to let the provinces choose what makes most sense to them. The organization of services is already very different province to province. I have 30 seconds left. I'd like to follow up on what you mentioned earlier. The consequences of COVID and lockdown, the fact that schools were closed because there was problems in the hospitals, socialization, physical and mental development. The consequences will be felt for how long? It's hard to estimate, but of course it'll take some time. Depending on age groups, it'll be more or less long. There are age groups which have been far more affected than others. I don't expect us to get out of this for at least 5 more years. I don't have any scientific basis for saying that, but there are studies that have been conducted. There's one in Chile that has been done on major school lockdowns. The effects were felt even in adulthood. So children were affected when they were very young, and this can last a long time depending on the measures put in place. So the duration depends on what we do now. What worries me now is we seem to be forgetting children. We seem to have gone on to something else now, and we're no longer investing in them and not longer talking about the effects of the pandemic on them. Thank you, Mr. Garon.
Please, for 6 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for being here. Dr. Heck, I'd like to start with you, please. A peer-reviewed journal article co-authored by you discussed the need for a, quote, unified monitoring strategy to address data gaps on childhood development indicators in the context of the COVID-19 pandemic. You and your co-authors noted a lack of both intersectoral data and longitudinal data. And there's going to be a lot of focus on data today as the provinces gather with the federal government. And I think we all acknowledge that the lack of unified longitudinal monitoring systems in most provinces and territories is cited as a barrier to the early implementation of preventative and therapeutic services. The Manitoba Population Research Data Repository is provided as a positive model. Can you outline for us what the elements of Manitoba's data repository are that might make it successful?
Well, en fait, les données, ce qui serait le plus successful.
What would be most successful, the best thing to our mind, would be if the federal government implemented systems to collect data on children and that data be protected and be high quality and put in centers accessible to all researchers. Historically, we had very good data on children. The National Longitudinal Study on Children and Youth was abandoned in 2008. That type of data is very important to understand child development. You can't look only at administrative data because, as other witnesses pointed out, we don't have the cultural community when you look at that data. We don't have religious background. There's all kinds of data that doesn't appear that's very important to understand the welfare of children. So we need a centralized initiative that collects data for all of Canada in order to compare provinces, and that data must be sufficient to look at smaller groups. I was listening to other witnesses say that you can't look at small groups. It's not that researchers don't want to look at small groups. I can guarantee you we do. But when you look at small samples, it's less valid because there are not enough people in the sample. StatCan wouldn't even let us issue that. I was at StatsCan for a long time. I know how it works. We need significant StatsCan funding for child health. They're almost 20% of our population, and I can guarantee that StatsCan does not spend 20% of its budget. We can have the labor force survey at every month.
Because I have other questions, but thank you for that. If I could move to Canada 3000. Sorry, 2000. It's inflation. According to Stats Canada, one-parent families with young children are almost 5 times more likely to experience poverty than couples with children of the same age. You've clearly made a link between poverty and poor health in children. In your view, what steps should the federal government take to address that disparity?
Thank you very much for the question through the chair. And I would point out that the majority of those families are led by single mothers. So the need for that intersectional disaggregated data would help us to better understand who these families are. That supplement targeted to low-income families that I was mentioning would actually drastically reduce the rate of poverty among lone mother-led families from an estimated 1/3 to about 8%, and it would do that very, very quickly.
Thank you, Dr. Salami. I'm a proud graduate of the University of Alberta, so I have to ask you a question. You've clearly linked the intersections of racism, poverty, and health among Black youth in Alberta. And I know you've talked about the need for more research, but I'm just wondering, of the research that has been done, do you have any solutions emerged yet that you would recommend that we adopt?
Yes, I think one of the things that has been repeatedly talked about in this panel is the need for us to focus on the causes of the causes. So we've already mentioned some of those causes: income inequality, racial inequality, and also gender inequality when you talk, for example, about single-parent families. For example, I've done research in the past on single-parent moms. Single-parent moms with Black boys face some of the Black boys living in single-parent mother households face one of the starkest disparities in Canada, including in outcomes, and providing much more support is important. When I've done interviews in the past, people have also talked about parenting programs. Oftentimes we think parenting programs are just for kids, but it's also family health. Kids are situated within the context of families, and when families have a better health outcomes, then it's better. There's also the need, and it's been talked about, the need for community-based mental health service delivery that is not just focused on institutions and acute care, but community. And in terms of talking about resilience, they need to create community belonging and strengthen positive cultural identity for Black and racialized communities. Spirituality is important, and building capacity of religious leaders, spiritual leaders, and also access to sport and subsidizing sports participation so that people are able to actually capitalize and build on their resilience. And addressing racism, I would say, is also of vital importance.
Thank you, Mr. Davies. Next, Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for being here today. I think just the variety of different topics that were covered in today's meeting shows how broad and perhaps challenging this subject is. And we've learned many times over in this committee that children are not just tiny adults, but they are their own entity with different challenges. And as a mom of a small kid, I see that on a very regular basis. I think my first question is to Ms. Sarangi. You touched on a piece that's very near and dear to my heart, and that's northern and rural communities. And after 8 years of this government being in place, we're seeing record high food inflation. And in my own community of Fort McMurray, Wood Buffalo, what we've seen is that now a third of the clients of the Wood Buffalo Food Bank are children, and the demand is rising month over month. And we're seeing more and more kids going hungry, and we know that kiddos can't learn if they don't have the adequate food. And so my question to you is specifically to northern, remote, and isolated communities. What do you think part of the solution is to this?
Thank you for that question. Again, I'm going to go back to the Canada Child Benefit and adding an additional supplement for families who are in northern and remote communities that take into consideration the cost of living. Families in Nunavut have extraordinarily high rates of food insecurity and of child poverty. And so targeting those families through an additional income supplement, it's easy to do because the administrative piece is already there. It just takes a bit more investment in the form of that additional supplement for those families. That is one very quick and easy way to start to address. Of course, there's more things that need to happen, but that is one very quick, easy kind of low-hanging fruit that you can just pick off quickly, I think.
Well, and I appreciate that, and I know that I call Fort McMurray home, and Fort McMurray's groceries are substantially more expensive than what we see here in Ottawa. And the further north I go, even in my own constituency, the more expensive groceries get, the more expensive gas gets. And I know as the carbon tax has been added on and is ever increasing, what we're seeing is that being passed on to consumers. And milk is now more unaffordable than it was before because the cost to transport the milk to some of these communities is that much more expensive. And so my question, I guess, what have you done any studies, or are there any research that's been done as to how much you would have to increase the CCB in order to combat this record-breaking food inflation?
We have not done that study yet. I think that is a very interesting question, and it's a question I can take back to my colleagues. We have done a study on the supplement for families in low income and how much it would cost to bring incomes up to the low income measure. And so in our submission, we have called for an investment of just over $6 billion for that end child poverty supplement that would really cut rates of child poverty from an estimated 9%, according to the market basket measure, to about 3% in the first year.
Wow, that's very, very shocking. And thank you for that information. And I guess to switch gears a little bit to Dr. Salami, as a University of Alberta alum, I'm grateful to see you here. And thank you for the work you've been doing. You talked a lot about the Black racialized. Have you done any studies on Indigenous and how that impacts?
Unfortunately, well, I haven't. My area of expertise is not. I'm a strong ally, and I know that there is a strong need out there.
No worries. I just wanted to see if you had. And then I guess my next question, it became very evident to me as you were doing your presentation that you were very supportive of community-based supports like churches, and multiple times over you talked about that. And I know, again, to draw back on my experience in Fort McMurray, when we had to evacuate, it wasn't the big bad government that came in and helped and made people feel good. It was churches and different community organizations that came from all over that opened up their doors and made my community feel so welcome in Edmonton and across the province. And one of the things that we've been seeing by this government is tightening up on financing for some of these church groups to be able to get summer students and restrictions being placed on them. Do you think that's a wise move?
Well, I will tell you, I did a study, analyzed the Canadian health measure survey to look at mental health of immigrants in Canada. No matter how much we analyze the data of 12,000 people on the Canadian health measure survey, the two strongest contributors to mental health was community belonging and income. When people feel they belong to a community, then they're more likely to rate their mental health as better. I've also in the past interviewed 300 families. And when people feel like they belong, the problem is oftentimes we expect community agencies to support or racialized communities to support, but we do not give them the tools and the resources to be able to actually support or improve mental health. So I would support any activities that actually provides tools to community organizations to building the capacity of religious leaders and building capacity of community organizations to be able to address and improve mental health.
Thank you, Dr. Salami. Mr. Van Couverden, please, for 5 minutes.
Thanks very much for all the testimony from all the witnesses. It's been extraordinary. I've been really excited for this study. I'm glad that we're focusing exclusively on children for a couple of weeks. It's been very clear from all witnesses today that the inextricable nature of income and health outcomes is critical, and we need to have a greater look at that. And when I have a look at those UNICEF numbers, I'm troubled as well when I see that Canada ranks so low. Weeks ago, I did a little bit of research on child poverty rates in Canada. And in 1989, actually, the House of Commons voted unanimously to end child poverty by the year 2000. Despite that, in 2013, it was higher than ever. Child poverty rates were worse than they were in the 1970s by 2013. And since then, gratefully, they've dropped by 71%, but they're still about 4.6%, 4.5%, which is too high for Canada. So I recognize that reducing child poverty doesn't instantly solve the problem, that health outcomes aren't going to change immediately, even over a couple of years. There's lots of studies that show that if you're poor as a child and not as an adult, then health disparities persist throughout your life, and that's something that we need to address as well. But through measures like making the Canada Child Benefit not universal, stopping sending $300 checks to every single family in Canada, and making it more of a means-tested program has been successful in reducing child poverty rates in Canada. But these numbers are still, not satisfactory, particularly on the rank of our OECD counterparts. So, Dr. Salami, my questions are for you. I loved your testimony. Thank you very much. I'm particularly interested in subsidies for physical activity for youth. I think physical literacy is one of the best precursors for later health. And how can we do a better job bridging the gap on those OECD numbers, bringing our rank closer to where we would like it to be, in the top 10, ideally, maybe even better than that for child health? you've answered the question already, but from the perspective of, recognizing that Canada has a low child poverty rate, but still really, disproportionately poor health outcomes, what can you point at in terms of the cause, and how can we do better?
I must say, poverty and income inequality does not exist in isolation. We also see, for example, racial-based inequalities and how that contributes to, for example, income inequality. So Statistics Canada just released a report that found, contrary to public opinion, African immigrants have one of the highest educational rates in Canada. Also consistent with popular opinion, African immigrants also have one of the worst income rate in Canada. Access to profession and addressing those underlying inequalities will support and help in terms of addressing issues related to poverty and also the consequences of that, issues related to poverty. So I think, one thing that has also been talked about in some of the interviews that I have done is access to the profession for internationally educated healthcare professionals. So we know, for example, people have said this, that the healthcare workforce or the general workforce in Canada, it's like a cappuccino. It's white on top, it's black underneath. We need to stir it up. And that has consequences. In the case of COVID-19 pandemic, it had consequences. We had a higher number of black people affected by COVID-19 because we had more black people at the front line providing the one-on-one care. We had more black people taking the bus. We had more black people with limited spaces. And that increased exposure to COVID-19 pandemic. So long-standing inequities that we experienced before the COVID-19 had significant impact on our experiences during the COVID-19. And it's addressing those racialized health inequities that will help us in terms of being able to address some of the health inequities that we experience.
Thank you. That's extremely clear. I appreciate that. And you mentioned sport, physical activity, recreation in your testimony, so I thought I'd maybe provide you with an opportunity to elaborate a little bit, since it's my policy interest as well.
Yes. So the youths that I have met, they talked about, for a lot of black youths, racism, a way for them to deal with the racism that they experience or the challenges or just the general everyday stress was to engage in sports. People talked a lot about basketball and being able to engage in that. Many of the youth discussed, during the pandemic, in some provinces, the bars were open, but the sports activities were closed. And they felt it was just such an inequity that, what could help kids was closed, but, the bars were open. And I think increasing access to sports and recreation, including subsidizing recreational facilities for low-income population, will help in terms of addressing health inequities.
Thank you, Dr. Salami. Suite, Monsieur Garand pour 2 minutes.
Mr. Garand, 2.5 minutes. Thank you, Mr. Chairman. I'd like to continue with Ms. Hack. The provinces are facing major financial constraints, far greater than the federal government. That was documented by the parliamentary budget officer. On the long term, we're in a situation where healthcare is taking up more and more space in provinces' finances, and the other missions of the state end up paying the price. The second most important budget item in the provinces is education. Since you've worked in both of these areas, I'd like you to tell me, according to your experience, what does it look like in Quebec? Let me reformulate that. Is it easy in Quebec to obtain funds, new budgets, to work on prevention or education for young children? What could we do at the federal level to facilitate the funding of the provinces for this? Thank you for your question. In my economy of the education course, I look at this issue of how healthcare takes up more money. That's true. All community services that support the most vulnerable are in this situation. The fact that we have underfunding of healthcare means that there'll be very little prevention. I'm at the obesity prevention program at the center in Quebec, and what we see there is there are all kinds of great ideas for children and adults in terms of prevention, but when it comes time to fund them, we have no more money for prevention. So all the money is for curative purposes, often older people, and that's normal. But that chronic underfunding means that there's no preventive measures. So obesity among the young in Quebec, all across Canada, has increased a great deal in the past 30 years. It's quite easy to solve with preventative measures that are well targeted. All doctors and people in the field have great ideas, but they have no money to implement them. So that's in terms of healthcare. When it comes to education, underfunding of education also means that we end up with many children who have all kinds of problems, and we don't have the resources to help them all because the money is redirected to other needs that seem more urgent. But we have to say here that children are our future. If we don't put money into that, we'll hit a brick wall. We have to wake up at some point. We can't always spend money on things other than children because it'll catch up with us later. We'll end up with a population that'll be very hard done by as adults. Thank you.
Davies, please, for 2.5 minutes.
Mr. Johns?
Mr. Johns, welcome to the committee. So nice to see
Mr.
you.
Casey.
You
It's
have
really
the
good
floor,
to be
sir.
here. Thanks so much to the witnesses for your important work. I was listening to you on my way over to replace Mr. Davies and really appreciate it. Now, I think what I really want to speak about is, in Ontario, there's 28,000 children on wait lists for community-based mental health. These services can range from 67 days to more than 2.5 years, depending on the service, exceeding clinically appropriate wait times. For children and youth, delays in accessing care, and I'm sure you can speak to it, can have lifelong impacts for themselves, their families, and society. And tragically, it can be a matter of life and death. And I know you talked a bit about UNICEF. Well, according to Stats Can, suicide is the leading cause of death among youth and young adults aged 15 to 34. And UNICEF has reported that Canada has one of the highest rates of youth suicide in the world. We've been waiting for 2 years for the government's promised $4.5 billion mental health transfer, which clearly is not even enough. Can you speak about the impact of the delay of that mental health transfer on youth? And maybe I'll just start with you, Ms. Basilian, if you want to speak to a bit about that.
Certainly, the area that I'm really focusing is children with medical complexities, more with disabilities. So I can't really comment with much evidence to give you around the mental health. However, I am in certainly close contact working with national groups, Children Healthcare Canada, and with my colleagues in the acute and community systems, and they are totally overwhelmed. So what I hear is they're not getting the sufficient supports. They're not able to sort of grow their programs to meet the demands. Certainly, we've seen the isolation and the mental health issues that have come from COVID, rise even in certain other, focuses on eating disorders in terms of also depression, anxiety. So my context that I'm giving you is really from working with my colleagues.
No, I appreciate that.
But certainly, I can certainly echo that. I know it's a significant challenge in Ontario across the country. Maybe my colleague, Dr. Salami, can also comment on that as well. But certainly, it definitely is a challenging area.
In terms of, I totally agree the need for community-based mental health service delivery. Right before the pandemic, we did a study in Alberta to look at the mental health of Black youth. So we've done one. We've done one before the pandemic, and we did one after the pandemic. And we engaged about 129 Black youth in conversation cafes and also interviews on their mental health. And on the last day of the conversation cafes, Black youth took us through what an ideal mental health service delivery will look like. So culturally appropriate, delivered in spaces that are accessible to Black youth, and also that are provided by Black mental health practitioners. Youth took that data and they used it to create the mental health clinic, the first mental health clinic for Black population in Western Canada during the pandemic. One of the challenges, of course, is that a lot of the funding for mental health is usually put into acute care, which usually is a downstream approach to mental health service delivery. And if we're able to address some of the upstream approaches, and before I talked about the need, for example, to look at community-based mental health service delivery to build and capitalize on the strengths of community leaders, religious leaders, while also understanding that not everyone goes to a religious leader. So we need community support and community to be able to actually address some of the mental health and also community-based service delivery. I've interviewed immigrant service providers before, and they've talked about the backlog in terms of being able, long wait list for people to be able to see mental health psychologists, counseling psychologists, and practitioners. And we just need much more investment in that in the community.
Thank you, Dr. Salami. Next, Mr. Generou, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for taking the time today. I think it's been a lot of the testimony has been quite fascinating, and kind of wanted to pick up on a journal article that you wrote, Ms. Salami, in CMAJ. And one of the quotes, this is from the October 24th, 2022 submission. One of the quotes in there says, and I quote, "Racism was the most frequent factor identified in contributing to mental health of Black youth in Alberta." As an Alberta MP, that was jumped out at me and was interesting. I'm hoping you can elaborate on some of those links between racism and discrimination and mental health and wellness in youth. Obviously, your expertise is in Alberta, but if there's other comments from across the country too, we'd certainly welcome them.
Thank you. So that project that I did was only in Alberta. Now, the survey that we're doing currently with 2,000 Black youths and 50 interviews is across Canada. So, and that project is, and in that project we interviewed 129 Black youths in that focus group, and the most frequently talked about contributor to their mental health was racism. So, for example, let's take the case of Black men, Black boys. Many of them discussed the perception that toxic masculinity was a Black male thing, which of course it's not. And they also discussed, for example, having always to prove themselves innocent because the first perception is that you're guilty. For everyone else, you're innocent until proven guilty. For Black people, especially Black males, it's you're guilty before you're innocent. So racism, one of the youths, I remember a quote she said, "God, I grew up with so much internalized anti-Blackness. I hated myself. I wanted to be white so bad. I wanted to have gray hair, lighter lips." And then she discussed her experience in crossing the street and someone throwing a sloppy at her and calling her, a bad word, a racialized bad word. And that continues to shape her perception because she's internalized that anti-racism, and it continues to shape her mental health. And those are some of the things that Black youths deal with in the province of Alberta, and as we've seen in interviews that we've conducted out in across Canada too.
Interesting. So I guess then what are some of those the best practices then that you can suggest to, we're at the federal level, but I would certainly welcome you to take the opportunity at diving into provincial and municipal as well. What are some of those best practices then that we can put in place? Like you said, your study is ongoing. Perhaps you'll have some outcomes at the end of that, but just initially, are there some steps that we can look at today?
Yes, so we have, the study is ongoing, the quantitative part, but we've completed the qualitative phase. And there are a few things. I think oftentimes we have, we are always focused on train for anti-racism initiatives. People get training, they get out of the room, and they leave everything in the room, and it's all done. We need to infuse accountability measures into our training. That when people, when people are racist, that then we can say they're incompetent in terms of, so infusing anti-racism, for example, in people's evaluation, in granting programs to ensure. I am always interested in in our, a lot of the funding programs will, for example, say you have to identify gender-based analysis plus. The only thing is people hear gender analysis and plus, and sometimes the plus is thrown away, or sometimes you don't know what a plus means, right? We need to spell out what the plus means. People need to understand, and we need to make sure that we collect data on that. And I think the other thing is race-based data collection is also very, very important, and will help in terms of addressing some of these inequities.
And you mentioned some of that in your earlier testimony, but thanks for highlighting it again. Also, what you mentioned earlier was some of the distrust in the Black community. I guess what factors influence that level of distrust?
Thank you. And in the early days of the COVID-19 pandemic, I am a member of Black Opportunity Fund, which serves to address anti-Black racism in Canada through raising a pool of funds. And in the early days of the COVID-19 pandemic, we organized town halls to address COVID-19 vaccine hesitancy. And I remember doing one of those town halls. One of the parents, said, is this another experiment that the government is doing on us? And we had to debunk that. So there's long-standing issues, for example, of mistrust. For example, studies that have been done, unethical studies that have been done within Black communities that Black people still know about or are acutely aware about. And also there's racism that Black people confront within the healthcare setting. And that's why I say the competence related to anti-racism is important. We need to, when you go to a lot of standards of practice for healthcare professionals, for example, and I know this is largely not in the federal jurisdiction, but I must mention, a lot of standards of practice do not even mention the word racism in it, right? So that means you can be practicing as a healthcare professional, and you can be racist and still be considered competent, because it's not seen as incompetent based on the standards of practice. We need to change that, and we need to ensure that anti-racism is infused into all evaluation and also into all standards of practice for healthcare professionals.
Thank you, Dr. Salami. Next, we're going to go to Dr. Pawlowski, please, for 5 minutes.
Thank you. I wanted to ask a question of Leila Sarangi from Canada 2000. Now, you mentioned in your testimony that there were some children of immigrants who paid tax but didn't get the Canada Child Benefit. So I was wondering, like, can you try to narrow this down, like which group of people you're talking about here that are in this category? I got my overpaid assistant Tyler over there to look this up for me. So Tyler, where is he? So he came up with this list. So he said the people that get the Canada Child Benefit is the spouse or common law of citizens, or the children who have, I guess, parents who are either citizens, permanent residents, protected persons, i.e. refugees, temporary residents who have lived in Canada for the previous 18 months and who are validly in the country. So can you narrow down the category of people you're talking about who are immigrants who pay tax but don't get the CCB?
Yes, there are people with precarious immigration status who have filed and are waiting for a claim to come through, who have been denied their immigration claim but cannot be deported because the government of Canada has deemed their home country too dangerous, so they don't have anywhere to go. There are people who are in limbo because of their precarious status. It is not a large number of people, and so it doesn't cost a lot of money. But in that category, they are considered residents under the Income Tax Act. So while they are waiting, they are here, they are working, they may be having more children born in the country, but they are still denied the Canada Child Benefit. So it's actually repealing that section in the Income Tax Act that is arbitrarily making that eligibility requirement that would have not a very big cost in the federal budget, but a very deep impact for these families who are dealing with a lot of issues and health-related health issues.
You talked about food insecurity in Nunavut. I would have thought part of the answer to that was the Nutrition North subsidy. Does your group have any position on those subsidies and whether those ought to be increased?
Our partners in Nunavut and the Northwest Territories have talked about how the subsidies go to the real retailers and are not necessarily passed on to residents. And so I get photographs of the cost of food in the grocery stores on a regular basis where it's about $75 for a piece of steak or $60 for diapers. It's outrageous food costs that the Nutrition North program is going to the retailers, but not necessarily being passed on to the residents, the local residents there, which is why we are calling for income transfers directly to families and to individuals.
That is a better way of addressing food insecurity than improving the Nutrition North program.
From our assessments, yes, that is one of the ways that we would prefer to see food insecurity in the North addressed.
Okay, if I can turn my attention to Dr. Salami. You mentioned the fact that, I agree with you, and I think obviously the biggest social determinant of health is poverty, but you just fleetingly mentioned that under COVID, perhaps that wasn't the case. Do you want to just elaborate on that? What was the greater social determinant of health under COVID?
So in 2020, the analysis that was done in Montreal, Toronto, Ottawa, on neighborhoods, and when you look at neighborhoods and COVID-19 distribution, found that the strongest determinant of whether or not you will get COVID in the early days of COVID was whether or not you were Black, not the concentration of Black people in the neighborhood. Before the COVID-19 pandemic, I'd always told my students that income was the strongest determinant of health. During COVID-19, I started taking caution. But of course, there is income. Racism does not exist in isolation. It intersects and it reproduces income inequality, and then intersect with income inequality. So that's some of the lessons that we've learned. I think what will be very important going forward is for us to start collecting those race-based disaggregated data that we did not have before COVID, to really shed light on how to ensure that we can have targeted interventions to address disparities.
No.
Thank you, Dr. Salami and Dr. Pawlowski. Next, we're going to go to Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you all for being here today. It's greatly appreciated. And I do appreciate your comments, particularly Dr. Hecht and Dr. Salami, on your comments on dealing with mental health, and in particular on the aspects of dealing with the impact of sports and education and how important that is. It's something very important to me, and recognizing that it was a great benefit to me many years ago when I was dealing with aspects along those lines. But with that said, I hopefully get to be able to ask a question on that. My main first question, though, is, and thanks to our analysts, we received some interesting information from CIHI, basically the Canadian Institute of Health Information, where they point out that medical complexities make up about 1% of pediatric population, and they're heavily users of the healthcare system, of which around 50% are basically total hospital costs, and quite significant numbers, which I see. With COVID, and my question, I guess hopefully just a general answer for maybe is, with COVID, unfortunately, it appears that we're seeing lack of education and public usage of emergency situations in bringing children to hospitals, which are tying up a lot of hospital situations, emergency rooms, with situations which might be able to be dealt with at home because of better education system, better understanding of the healthcare system. And these are important things. I guess my question is, how do we get that education to Canadians such that they understand it? And what we saw with COVID, and we've seen over the last couple of years, is basically uncertainty and misinformation that the public believes is coming from government. And so we as a federal government are trying to deal with something that is provincial in nature. But how do we, as a federal government, maybe advance that education such that we can educate parents to understand how to deal with health issues for their children? Ms. and I apologize for pronouncing your name wrong, but Ms. Bazilian?
Well, thank you so much. And no, you're absolutely right. The Kai study was really a really important study that was done. I was in the last few years. We're hoping to get it updated, the information. The complexity, that top 1%, you're absolutely right, take up a huge component of the dollars. And in terms of then thinking about how we work with families, there's not well-established programs. There's not a lot of data. And as I listen to my colleagues, I'm really see that there's a huge issue with data with our population. But certainly those families, they may be supported in the acute care sector. And that's why they go back to a lot of the hospitals, because we don't have well-established continuum of care support. So families need to have stronger supports in the community. They need to help understand how to cope in the community so that we're using our healthcare system, acute care for acute care, and have well-established home and community-based cares where families then can cope. Right now, the system is the way it is. We don't have that cross-continuum support. So that's what I've been advocating for, so that we have an established system of care across outside of hospitals. So families don't have to go to the hospital, to your point. Parents can access, services in the community as opposed to going to an emerge department.
And thank you very much. I appreciate that. And perhaps if any of the other witnesses have something where they'd like to answer on that, if they could provide that to the chair or to the clerk and analyst, and we can get that out, I'd appreciate that. On the issue of when we're dealing with and looking at sports, and Dr. Salami, you talked about that, and you talked about one of the recommendations was possibly reinvestment in sports targeting with youth, especially for Indigenous and Black populations. And I think I agree with you 100% behind that. I see such a benefit for sport, and unfortunately because of COVID, we lost that ability to get people out. I'm just wondering if you have any further comments along those lines, because a lot of it, we start to look into the issue, and you sort of touched on suicidal ideation and that aspect, and participating with groups and together, that sort of helps to communicate amongst each other. And Dr. Salami, any comments along those lines?
I think, one of the things about sport is, it goes through several pathways to influence health, whether it's mental health, physical health. And we know that sports also contributes, as I said, community belonging is one of the strongest determinants of mental health, at least based on my analysis. And sports can also help in terms of fostering that belonging and social inclusion of Black and racialized kids. So I think it's of vital importance, especially in light of recovery from the COVID-19 and the separation and the social isolation that people have experienced, to invest in sports activities for all kids. But also to ensure that it's subsidized for those that are much more marginalized within the society.
Thank you, Dr. Salami. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses, for your valuable testimony. My first question is to Dr. Salami. You talked about racism, but what role do culture and language barrier play in affecting the health outcomes of immigrant children and youth when they don't have any awareness for vaccination or disease prevention? So how the outcomes come?
Thank you so much. And, when someone asked about improving access to emergency services, I think one of those things is addressing issues related to language barrier, addressing issues also related to culture as a social determinant of health. Years ago, the Public Health Agency of Canada used to have racism subsumed under culture as a determinant of health. Now we realize that there are much more differences in terms of racism and culture as a determinant of health. So yes, it's very important in terms of being able to address culture, and it's also important to address issues of racism, and also to address, for a lot of immigrants, system navigations too, just knowing where to go and how to navigate the system. And in terms of language barrier, oftentimes we think about, language barrier in terms of, you speak Arabic, you speak Arabic, just come together, and you can interpret for each other. and voila, everything is all done. But some of the research that I've done tells us that there are complexities in terms of interpretation services. So, one of the participants that I've interviewed, immigrant service provider, talked about, for example, if you have two interpreters, one is from the Taliban tribe, one is from the Pashto tribe, you bring them together, you say, interpret for each other. There may be clashes in that because you're bringing the oppressor with the oppressed. So there are delicate aspects also in the terms of gender-based violence. Sometimes you may want to match based on gender. So there are so much complexities in terms of culture and interpretation service. And yes, without interpretation, it makes it so much challenging to be able to address the needs of immigrant populations in Canada.
Thank you. How can healthcare providers better serve the needs of immigrant populations, particularly in terms of language and culture? You already talked about that. But can you also discuss the importance of research and data collection, which is very, very important, and how we can improve that gap? What data and research are needed to better understand the health needs of children in Canada, and how can the federal government support the collection and analysis of this data?
So I think we need disaggregated data. And one of the challenges, and one of my colleagues said this, when I've tried to, for example, I did a study where I looked at mental health of immigrants and non-immigrant kids in Canada. When you look at all the data together, everything gets clouded. But then when you start disaggregating, the problem is that when you go, for example, to the Canadian Community Health Measure Survey, which I tried to use, you cannot disaggregate the data. The analysis is just not possible. When you go to the Canadian Community Health Survey, which has the largest sample size and which maybe you may be able to disaggregate the data, they do not collect data on children less than 12 years old. So maybe that's one of the places that we need to begin, to start collecting data. My colleague talked about the longitudinal survey of immigrant children and youth, which was also providing disaggregated data related to immigrants in Canada. And there was another national study. Many of those longitudinal studies have been discontinued. When you look, for example, at many of the data that longitudinal, small niche longitudinal data across Canada, some of the challenges is that the sample size for immigrant population, for racialized population, is so small. I am currently doing a study looking at, for Public Health Agency of Canada, looking at how do you collect race-based data for Black populations in Canada. And I think there is culturally appropriate ways that we must infuse into our race-based data collection to ensure that we have appropriate sample size. Because right now, at least I know with the Canadian Health Measure Survey, with the Canadian Community Health Survey, the percentage of Black racialized immigrant population interviewed and surveyed in those surveys is actually less than the amount of people in the Canadian population. And that has to change so that then we are able to disaggregate our data.
Thank you. Mr. Chair, do you have a time?
No, there's about 10 seconds left. You don't have enough time to ask a question.
Okay, thank you.
Thank you, Ms.
Any
Sidhu.
last comment, Ms. Basalin, you want to say on that? Any last comment you want to say on that?
No, I think, just listening to the conversation is so interesting, but I think for me, I also think from the perspective of vulnerability. So I deal with a lot of clients and families who are new immigrants, refugees, who are coming into the country, and they're layering over the fact that they're new to the country and there's issues because of access. And I think some of the comments that I just want to emphasize is the trust of the system. I know during COVID, I had a lot of experience on the ground with Indigenous communities and other sort of marginalized communities. And there is a lot of work to be done in terms of educating our healthcare, colleagues and frontline staff about culturally sensitive care and, working with people of different race. Because there's a lot of biases there. And I think that goes to your point about, the standard of care. If you're in the healthcare system working, there should be standards around how we interact and work with people of different culture and backgrounds.
Thank you, Ms. Bissayon. Suite, Monsieur Garon pour 2 minutes.
Mr. Garon for 2.5 minutes, please. Thank you, Mr. Chairman. I find it very interesting that we're talking about data, including data that enables us to have good social policy and compare each other. That's the flavor of the day, it seems. So my question is for Ms. Heck again. I get the impression that every researcher or group of researchers want their own data, and we have small initiatives for very particular collection of data. What would be the ideal model in Quebec as well as in Canada in order for researchers to have data that's accessible to all, that's comparable, that's accessible, and that would put Canada on the world stage? Because we're using a lot of American data on many issues. What would be the right model for us to have data? And do we have that model today? No, we don't have it today. What happens is we have many initiatives funded by the federal government that fund all kinds of projects across Canada where people collect their own data. And what happens is they don't share that. It consider it their property. It's public funding, but it remains their property. The data is not accessible to other researchers. So the best way to operate is to go through Statistics Canada so that the investigation is done with recognized methods, that it's representative of the population, that they're important subgroups. Allow me to interrupt you. How come it's not the case yet? How come we're still decentralized and we don't have that model? How do you explain that? I'm surprised by your answer. I have no idea. The data used for the UNICEF report are HSBC, funded by Health Canada, that are inaccessible to researchers. I've tried. It's impossible to get that data, which is collected with public funds and that places Canada on the world stage. These are not StatsCan data. We can't verify the methodology. It's not obvious to verify, and they're not representative of Canada, these samples. So giving this to a group of researchers rather than StatsCan makes this makes no sense. I don't know by what logic this was done, but there's a lot of that kind of funding across the country. Thank you, Ms. Heck.
Johns, please, for 2.5 minutes.
Ms. Sarangi, in 2022 in May, the Auditor General, Karen Hogan, she did a report and she cited around the CCB that the government has not done enough to help hard-to-reach Canadians access the benefits they're eligible for, and they failed to improve the lives of individuals who need the help the most. And she cited Indigenous peoples, housing insecure individuals, new immigrants, newcomers to Canada, refugees, and people with disabilities is certainly disproportionately being impacted. I see that in my own riding, certainly with Indigenous peoples that might be behind on taxes and whatnot. But they cited it lacks insight. What changes need to be made on your recommendation? You talk about the costs of families not getting the CCB as a result of these failures.
Thank you for the question. The changes that need to be made, automatic tax filing will go a long way. It will help people who have filed taxes in previous years where CRA has their information. They can automatically file taxes, and then individuals can go back in later and make any adjustments. So that's something that was in mandate letter to the minister. We feel that should be moved on. There will always, we need to broaden that income tax system using those kinds of initiatives, more community-based.
Yeah, so there's still no comprehensive action plan. Can you speak about the cost of that on the children that are impacted?
There's a lot of, there is a deep connection between material deprivation that comes along with not having access to those benefits. There's a lot of money that is left on the table from families who are not filing taxes, who don't have access to that money. That means children are going to school without the right kinds of clothing, without food in their stomach. Families are missing out on medication. Rents are not being paid. I think as we're talking about some of those social determinants of health, we need to look holistically, including at how to keep people housed adequately, how to make sure people have access to medications. These are things that families have trouble, those basic needs. They cannot access that if they're not receiving their income benefits. And that leads to a lot of stress in families, and it leads to worse mental health and all of the outcomes that we've been hearing from all the panelists today.
Thank you, Ms. Sarangi. Next, we're going to go back to the Conservatives. Dr. Ellis, please, for 5 minutes.
Thank you very much, Chair. And I think, as I said at the outset, it's been a very interesting panel to understand the plight of children in Canada and perhaps some of the way forward. I had a question for Dr. Salami, if I could, and then I'd like to turn to the other witnesses in a different vein. But Dr. Salami, you specifically referenced credentialing of internationally trained healthcare workers, and I guess I can well imagine that that sets a great example for children and families, and of course, generally speaking, jobs in the healthcare sector are perhaps better paying than others, which again helps kids. Can you talk a bit about any ideas you may have about credentialing international healthcare providers?
I should preface by saying my doctoral work was actually on the migration of Philippine-educated nurses to Canada to work as domestic workers in Canada. And that was about 9 years ago, but some of the issues still exist now. I am also on some WhatsApp group for some internationally educated professionals. And in the past, I have helped to organize information sessions to bring together National Nursing Assessment Service with internationally educated professionals. There are small things that we can do, and there are big things that we can do. And in some of those sessions, internationally educated nurses have talked about even just a small thing as the length of time it takes in terms of credential assessment, or being able to have a checklist on the website so that then when I'm sending my documents back home, those back home know that this is the things that you have to provide for internationally educated. In terms of provinces, there's so much differences in requirements, English language requirements, other requirements, and 3-year entry into practice competence requirement that you must have practiced in Ontario within the last 3 years to become an internationally educated nurse. When you go to Alberta, it's 5 years, right? Why is there so much differences across Canada in terms of that? I think opportunities that also allows professionals to be able to practice across different provinces may also be beneficial for internationally educated professionals. So I think, for example, at the federal level, a lot of the policies related to internationally educated professionals, unfortunately, they are at the provincial level. But at the federal level, we can do more by supporting nursing national nursing assessment services to be able to facilitate. So, for example, one of the things right now is a lot of the processes related to credential assessment for internationally educated nurses, it's actually done in the U.S., right? And that slows down the process. Now, if we want to really, really hasten, right, we make it that it's done in Canada, it's going to cost us more. But then how much more gains are we going to have in terms of patient outcomes and supply of human resource in Canada? I think that's one thing that we have to explore. Is it possible to actually have things that are done in Canada so that then we are able to move internationally educated nurses faster through the system?
Thank you very much. Certainly doing more things and making more things and having Canadians prosper really makes sense to our side of the house anyway. That being said, I had a couple of other questions, just changing gears a bit. Professor Huck, if I might, you talked about school closures and certainly a difference in Belgium. Were there any Canadian jurisdictions that you know of that did a better job than others? And not to create disparity, but to look at lessons learned as we go forward.
In terms of school closures, it was pretty uniform across Canada, but there were some provinces that reopened school a bit faster. So in Quebec, we reopened school a bit faster than elsewhere. But then again, it wasn't that much faster, so it didn't make a big difference. And I know that in Ontario, schools were closed a bit longer than elsewhere, especially in Southern Ontario, like in January 2021, it was closed for a while. So thinking about it, and I love this about Canada, that we're able to do different things and learn from each other. So I think we should really try to learn from what we did. But the problem is we don't have data to learn from all of this because we didn't collect data on kids during the last 3 years. So yeah, there were some provinces that were marginally better, but nothing fantastic.
Thank you very much. I think I'm almost out of time, Chair. I'll cede the rest of my time. Thank you.
Thank you, Dr. Ellis. Next, Mr. Johari, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses. Very great testimony, and focusing on many things, whether it was the social determinant of the health, the impact of COVID on the most vulnerable, talking about the data, talking about some of the research that was done around intersection of gender, race, class, nationality. A lot of questions that I had got answered, but I'd like to take a little bit of time and look forward, and specifically look at the policies that exist and the practices that exist and the opportunities there, and what we should really focus on to address some of those challenges. So with 4 minutes remaining, I'm going to go to each one of the panelists here and ask them for a 1-minute intervention. If you could give us one policy area, and I want to acknowledge that health is a shared jurisdiction between provinces and territories as well as the federal government. If it's one area of a policy that we could focus on to help improve or eliminate some of the challenges that you highlighted, what would that be? And that would be really helpful for our study. So in the order that they presented, I'm going to start with Madam Hack. Can you please give us that one policy that you think we should be advocating for?
Who's it? Ansodin.
You're on mute again. I pressed on the wrong button. Sorry. When it comes to policies, we're looking at daycare across Canada. I think that's a good initiative. It should be possible to offer high-quality services to the most vulnerable. Everything's important for children under 5, so we should really concentrate our efforts there and do a good job across Canada. That's where we should be going. That implies collecting data and do a good job on that, because just sending money here and there is not going to help.
Thank you. I'm proud to announce that our government actually made sure that the $10 daycare is a reality now. So thank to all the provinces who participate on this one. So next we go to Dr. Salami.
I would say addressing racism as a social determinant of health. As I said, the healthcare workforce, there's segregation in the healthcare workforce. And how do we have interventions that actually ensures that there is diversity across all levels of the healthcare workforce, from leadership position to frontline service delivery?
Thank you. That's very informative, especially on the, on the timing is perfect, as we are about to release our findings as it relates to the healthcare workforce. Next to Madam Sarangi.
Thank you. I've talked a lot about the Canada Child Benefit and what can be done to broaden and enhance that. I think our bottom line is raising incomes for families. That goes a long way, and studies have shown how raising incomes in low-income families leads to better overall health and wellness and better outcomes for children. Just because the daycare model has been mentioned, ensuring that all expansion of that daycare goes into the public not-for-profit daycare systems, and that it's accessible to these families who are on low income. Campaign 2000 has worked with advocates and researchers to put forward a $0 to $10 a day maximum sliding scale model for to make sure that it is accessible to the families that we are concerned about who are on very low incomes.
Thank you, Madam Sarangi. And last, Madam Basilio.
Thank you. I think, a lot of the work you're doing with Bill C-22, this is very exciting. So I think I really encourage you to embrace that new legislation and see what we can get at it. What I really want to emphasize today is that being born with a disability and a complexity should not mean that you are living below the poverty level. So it's really addressing the poverty and also making sure as these children age from childhood, when they reach 18, that they have a successful transition and affordable place to live. So that would be my request to leave with you today. Thank you.
Thank you. So when I listen to all four of you, focusing on daycare, focusing on ensuring that our healthcare workforce is empowered and it's diverse and it's inclusive, and strengthening CCB and making sure that the most vulnerable and those who are in need are not left behind. This is very much aligned with what our government has been doing over the last 7 years, and I'd like to thank you for your testimony today. Thank you, Mr. Chair.
Thank you, Mr. Johari. Next, Ms. Goodrich, please, for 5 minutes.
Thank you, Mr. Chair. And I guess to go on that same vein, Ms. Bissalian, I think the work you do and the work that your organization does is spectacular. I know in my community we're relatively northern and isolated, and so we don't have a lot of those extremely specialized services available, which means that a lot of families that do need those services end up traveling down to either Edmonton or Calgary, and oftentimes end up relocating to those centers just in order to be able to get the specialized care. You highlighted about having more services available in communities and having more respite. I was wondering if you can expand a little bit upon models that have worked in smaller centers to allow for some of those places to exist.
No, thank you. I think it's a great question, and I think that we know that when children are born and have complexities and life-saving needs, the best place for them is in the large academic health science centers, and we have those centers across the country. You talked about Calgary, Alberta, Edmonton. We have them in Toronto. But the thing is, once these kids become stabilized, the development of really strong programs in these remote communities, you can have good respite programs. They may be small. It could be a small setting, but having those hub and spoke models, so having that interconnection between, say, if there was a program that was provincial or national, like an organization, you could have sort of those supports for those remote communities. And the only time then they would need to access the large academic centers in the large centers is when they have sort of an acute episode. So then they would need to go there. But there are mechanisms to develop it, and families shouldn't have to relocate. You can do it in small pockets. I think what COVID has made us do, which we've done extremely well, is pivot towards virtual care. So there's opportunities to use virtual care technology. Like we overnight had to switch from going to in-house for all of these sort of visits in academic centers to doing virtual care. So I think the technology exists. There's monitoring capabilities for monitoring children in these remote communities. And then also then it gives you a sense of some precursors, so when there is decline and when they should go in. So I don't think we should shy away from this notion of remote supports, but really using technology, virtual care, and like hub and spokes models to support families close to home.
No, and thank you. And I know, like, we've got one little super special little kid in my community of Fort McMurray, Madden, who's dealing with Batten's disease. And so for the first chunk of time, they did have to go down to Edmonton to get all of his injections. But through working with the Stollery and the Stollery Foundation, he's now able to get his injections in our community, which means the family has a little bit more stability and they have more supports, because frankly they don't have the same level of supports when they're 5 hours from home. And so I think that these kinds of things are spectacular, and I'd love to see more of, because I think our communities benefit when we have a more wholesome support of that. Are there any jurisdictions that are doing a better job when it comes to some of that innovative work?
So I would say that certainly I'm very well connected nationally. I chair a community practice for healthcare professionals across the country, so I have a sense of that. And I think what I was trying to emphasize today, that we're still very much in our infancy around these programs. I think there's pockets that do it extremely well. You know, when I look at the East Coast in Newfoundland, I see some really great home care options. Certainly, I've been working with my colleagues in British Columbia who are doing some really neat sort of work and expanding the notion of medical complexities into health complexities. So rather than just look at the physical health, looking at the mental health, we're trying to be broader in our thinking. But also Alberta's doing some excellent work. So everybody's trying to work together and really build on what each province is doing, but we don't have an integrated, sustainable model. So I think, having those supports are really important. And to your point, I think families shouldn't have to move to these large cities. They can be successfully cared for. Technology and medical innovation is really exceptional, and I think we need to be much more strategic and innovative. And I think this committee has the ability to help us sort of start to do some of those models.
Thank you very much, Ms. Goodrich and Ms. Bizayon. That brings us to the top of the hour. I want to sincerely thank all the witnesses for being with us today. When the committee decided to embark on a study on children's health, we knew that it was a very broad topic, multifaceted, and that is evident in the diversity of the experience, the expertise, and the advocacy that you've brought to this very interesting discussion, and we're very grateful to you for that. So thank you so much, everyone. Is it the will of the committee to adjourn the meeting? We're adjourned.